Hello everyone, I am Bahadır Turan. I'm a pediatric psychiatry specialist with Ağrı State Hospital. I'm going to talk about ADHD in the later periods of life. This is a study this is a field which is studied less compared to the childhood age. I'm going to talk about certain clinical experience and some of the studies in the literature in relation to ADHD in the later stages of life. Well, we can say that attention deficit hyperactivity disorder is a chronic neuropsychiatric disorder that may impact 3% of older adults. Of course, diagnostic assessment of adult ADHD has been recently refined, but we know that comorbidity, symptoms, and treatment options may be different. Especially the first-line treatments may vary based on patients and cases. So basically, we don't have systematic studies in this age group in ADHD. And that's why we have to go on a case-by-case basis. This is in 7 of the prospective longitudinal studies with the biggest scope. We see that there are some genetic connections, but these studies usually exclude individuals about the age of 65. But I should note that with the increase in aging population, there is also an increase in number of studies in this field. And you know about the estimation of aged population in the States, and the projections are indicating some very high numbers. Well, I'm going to talk about 4 epidemiological studies. The first one is the NESARC study, the National Epidemiological Survey, and this screened around 35,000 individuals who were adults, and 35% were over the age of 45. The other one was a LASA study from Amsterdam, which covered almost 1,500 participants from the age of 55 to 85, and another study was a Germany-based DES1 study, which covered 1,655 adults from 18 to 64 years of age. The general prevalence was 4.7, and they also calculated prevalence from 55 to 64 years of age as well. And finally, we have Galtberg-Jar study from Sweden, and this was finding 3.3% of people, which would cover the data from childhood and also adult ADHD. Well, there seems to be a consensus on the prevalence of ADHD with prevalence. The main finding was that ADHD is decreasing with age, and we can know that the incidence is going as low as 3%. Well, why is this happening? There are many opinions as to why. I think the most remarkable one is diagnosis-related considerations, which are related to age. And of course, there are cases of normal aging and also some aging-related medication use, which makes diagnosis more difficult, and also emphasizing the impact of inattention symptoms and not just hyperactive impulsive symptoms. So in adults from 40 to 45, these individuals, they were not diagnosed with ADHD as a child. And so all of these factors may require clinicians to reassess the aging group for ADHD. So how do these people present to us? How can we recognize them? Well, the criteria we have are not very different from the ADHD in young adult ages. Of course, there needs to be an impairment of functionality or an impact on academic or professional performance, and this is proven better in the younger population, but we have to be careful because the functional impairment in the elder population is beyond work or school performance, of course. So the self-report screening scale of adult attention deficit hyperactivity disorder was done by the World Health Organization. Maybe we could check that and remember the criteria. According to this, the inattentive presentation symptoms include failing to wrap up the final details of a project once challenging parts have been done, or having trouble getting things in order when performing a task requiring organization, or having problems remembering appointments or obligations, or avoiding or delaying getting started on tasks which require a lot of thought, or maybe have difficulty paying attention when doing boring or repetitive work, or having difficulty concentrating on what is being said, or misplacing or having difficulty finding things at home or at work, or having difficulty finding stuff around the house, or getting easily distracted. And hyperactivity symptoms include being fidgety or squirmish with one's hands or feet when having to sit for a long period of time, or often feeling overly active and compelled to do things, and often leaving one's seat in meetings or other situations in which they are expected to remain seated, or having difficulty waiting in a line. Well, of course, we need to have 5 or more of those for a duration of 6 months, maybe, or present prior to the age of 12 years, or these symptoms interfering with the functioning of these individuals. So we have 4 specific case reports which are diagnosed with ADHD over the age of 50. One is a case report of a 68-year-old woman with DSM-4 ADHD. Another one, 9 women between the ages of 62 to 91 diagnosed with ADHD in Texas. A chart review in Israel of 11 individuals is another one. Also 60 individuals over the age of 65 selected from a Swedish population. In this subset of the LASA study, individuals with the age of 84, they found this relationship, this common characteristic, being divorced or never married, and emotional or social loneliness. These were found to be correlated. So, other than case presentations, there are this kind of clinical presentations as well. And other than that, in terms of the other clinical presentations, there is also presence of chronic non-specific lung diseases, cardiovascular diseases, number of chronic diseases. The DB symptoms the ADHD symptoms seem to be correlated. Also self-perceived health. However, there was no association between substance use, exercise, or other lifestyle variables and symptoms of ADHD. Well, in the geriatric stage, I'm going to talk about some tools which are used for identifying ADHD symptoms. Well, we don't have a measurement tool which can be fully validated in the geriatric population, because we don't find a strong correlation between the symptoms from the young adult stage to the geriatric stage. So maybe a self-report, self-screening report, which combines the questions from the young adult to the geriatric. But when this was tested, the test validity was not found to be very high. and its sensitivity is 0.80 and specificity also low. So this contains 10 questions of yes/no characteristic. So it's about getting easily distracted or maybe impulsive decisions. Can you start a project without reading the instructions, or you have poor communication skills with others, or do you have difficulty doing the things in the right order? Or if you are driving, do you tend to drive faster than other people? Well, these people are called speed devils. And do you have more difficulty in a task than others? Or do you have difficulty focusing on the rules of a game? And did these symptoms start before the age of 16? Another one which I just mentioned is the self-report prepared by the World Health Organization and DSM jointly. This was used in an Australian study, the Australian Personality Total Health Study, PATH, and the symptoms were found to be, it means, or what they defend is the geriatric group can be diagnosed using less criteria compared to the younger population. And again, they did another DSM screening. Again, they found less symptoms in the older population. And so in the older population, there are certain findings and studies which support the idea that the criteria should be less in the elder population. Another inventory was used in the Swedish study, and they found some correlations, but they said it did not fully predict. And so hyperactivity and impulsiveness, they're also similar in terms of their results. I'd like to say a few words about comorbidity. These studies, the case presentations, show that well, this kind of findings are more in the older population. And I'd like to first talk about the Texas report, including 9 women. There were depression, 2 had bipolar disorder, 7 had anxiety disorders. 6 of the 11 Israeli cases reported axis 1 or 2 comorbidities, and analysis of LSA subset study of adults aged 60 to 94 years found association of ADHD with anxiety, depression, and in conclusion, overall the rate of comorbid psychiatric disorders was 3 to 7 times more than that of general population, and the data from NESARC study has shown that it could also be related to certain personality disorders as well. This table is about differential diagnosis in the geriatric population ADHD. Well, of course, there is the aging process itself. There are also psychiatric conditions, maybe dementia, also mild cognitive impairment. I want to first talk about mild cognitive impairment found in 16% of the geriatric population. Also, dementia symptoms overlap with ADHD, but of course may have apraxia, aphasia, and primitive reflexes, which point more to Alzheimer's. And if there is maybe problems with some attention, maybe it is going to point in another direction. In this group, especially The post-concussion syndromes or traffic encephalopathy seem to present more with ADHD cases. But unlike ADHD, pain or maybe dizziness or photophobia can be found. So this complex structure is one of the main reasons for ignoring ADHD in the more older population. There are 62 memory clinics, and in only 1/5 of those centers, the ADHD screening is being done. This is the situation, and I'd like to talk about treatment. And I don't think there is a very comprehensive study about this. I found some studies. The first of these is Manor et al. Covering 11 older adults, 2 months. So only 8 reported significant improvement. In a US survey, 25 adults diagnosed with ADHD from 60 to 77 years of age all had on medication, and all but except 2 reported benefit. And also 149 patients in a Norwegian study, 64% of participants were on medication, meaning those on methylphenidate and amphetamine. And in this last study, self-reported methylphenidate dose was 54.1 milligrams. These are the drugs approved by FDA in adult ADHD. Stimulants, mixed amphetamine salts, and I think this was 65 years of age. What should we be careful about? We have to be careful because they can increase sympathetic tonus, and we should diagnose or follow up hypertension, arrhythmia, urologic sexual function, and narrow angle glaucoma, and poor peripheral circulation. But when it's combined with cognitive disorders, we don't have any data suggesting that the outcome will increase. In 2 cases, there was delusion, agitation, insomnia, and appetite reduction as side effects. Again, the FDA-approved drugs are contraindicated in symptomatic patients, and routine AKG is not recommended in this group. There is a pharmacokinetic study in the renal or hepatic function, and they found increased serum concentrations, but the creatinine concentrations did not change. There is limited evidence showing methylphenidate preventing this in the older group, and also there are evidence that amphetamine is not changing a lot because they are thrown out of the body through the kidneys. Also, bupropion or Psych2 and inhibitors, they are not recommended a lot because of their metabolic effects. So what is the search for treatment in this group of patients going like? We really don't know because there aren't enough studies, but we know that it is less than the search for treatment in the young and adult group. We know that less than 50% of people in this group are searching or seeking medical treatment. Also, the medical stability, symptom severity, or treatment seeking of the persons, maybe medication or cognitive behavioral therapy could be first line. Well, there are some studies in relation to children, but this is not checked with results in the older population. There is good evidence that behavioral therapies may improve daily coping and daily functioning. Thank you very much for your attention.